Thank you for joining us on this webinar hosted by BioLace NG and with our special speaker, Dr. Paul Chang. Thank you for doing this for us. Dr. Chang is one of our key opinion leaders at BioLace NG and a pioneer in the peri-waterlace world. Um, Before I hand it over to Dr. Chang, we'll be doing Q&A at the end of the webinar. So please, if there's any questions, put them on the chat, and then we'll go ahead and get those at the end of the hour. All right. Without further ado, Dr. Chang, the audience is yours.
Oh, thank you. Thank you, Javier. Good afternoon, everyone. It is a pleasure to be presenting on one of my favorite topic to you, managing peri-implant complications and peri-implant disease. So it is hard to believe I have been in private practice for almost 15 years now. My main focus nowadays are dental implants in aesthetic zone and managing dental implant complications. Everyone agrees that dental implants have revolutionized the field of dentistry. Since Professor Brennemark placed the first implant in a dentulous mandible some 60 years ago, dental implant has become standard of the care. That's because dental implant restorations offer much better aesthetics and function compared to traditional prosthesis. Today, implant dentistry is a $1 trillion industry. According to iData research, between 3 to 5 million implants are placed every year in the US alone. For the last 7 years, there has been more than 30 million implants placed in the United States alone. And this is from 2017 to 2025. However, along with success come with complications and failures. Otherwise, we wouldn't have so many people attending this webinar, right? Before I start talking about implant complications, let's review criteria we look for in a successful implant restoration. Clinically, a healthy implant does not have gingival inflammation, no bleeding on probing, no suppuration. In general, probing depth should be less than 6 millimeters. There should be presence of adequate carinized tissue to help protect underlying attachment apparatus. Radiographically, the platform switched internal connection implants. We should expect to see bone at or coronal to the implant platform. How long should we expect an implant restoration to last? That's a tricky question nowadays, isn't it? We used to say once you get an implant, it will last you a lifetime. Anywhere here still telling their patients that? If we look at specifically at peri-implant mucositis and peri-implantitis studies, the clinical studies and the retrospective meta-analysis studies have shown that at 5 years, 50% of implants would develop peri-implant mucositis, and around 12% of implant would develop peri-implantitis. When we get close to the 10-year mark, peri-implantitis case almost doubled to 22 to 45%. If we go back to iData research data and do a little math, around 30 million implants placed in the United States in the past 7 years alone. Within the next 5 years, we will have 9 to 15 million implants that would develop implant mucositis, and 2 to 3 million develop peri-implantitis. In case you haven't noticed, management of peri-implant disease has become a hot topic at all perio and implant meetings. Implant complication can be divided into two main categories. Early, failure to integrate before restoration is attached. Late, complication arises after occlusal load. Early complications can occur in patients with compromised systemic health, but mostly happens to cases where there's insufficient bone volume or quality. And poor implant placement by inexperienced surgeons, such as this case. It is important we spend time prepare for implant surgery by reviewing CBCT and use surgical guide as necessary to avoid placement like this. Immediate implant placement after extraction has been a hot topic lately. If you want immediate implant to be successful, complete granulation tissue removal and root fragment removal is a must. In edentulous cases, implant must be placed parallel to each other and perpendicular to the occlusal plane to ensure an optimum path of insertion and proper prosthetic alignment. This reduces off-axis loading, which can generate harmful lateral stresses, increase screw loosening, contribute to component fractures, and accelerate crestal bone loss. Late complications occurs after implant has been integrated and functionally loaded. These could be caused by ill-fitting restorations, biomechanical overload, and ineffective maintenance. Let's look at this case. Patient reports tenderness and bleeding around the implant. Implant restoration was just delivered about a month ago. What do you think is the issue? That's right, excess cement. Depending on what type of cement that was used and how much was left subgingivally, residual cement may not always show up on the x-ray. In some cases, can remain undetected for years before clinical signs appear. In this case, implant was placed more than 7 years ago, had been functioning well until recently. The hygienist noted progressive bone loss and increase in bleeding on probing and suppuration. Excess cement was identified as a major contributing factor in the development of peri-implantitis by Tom Wilson as early as 2009. As a result, many clinicians shifted from cement-retained restorations to screw-retained restoration in an effort to reduce this risk. However, the important question is, have we eliminated peri-implant disease as a result? The answer is no. While screw-retained restoration reduces the risk associated with residual subgingival cement, peri-implant disease is a multifactorial disease. So let's take a look at a few other factors. As you guys are aware, not all screw-retained implant crowns are fabricated the same. First is what we call a hybrid abutment, which is made using prefabricated titanium base and a milled one-piece ceramic crown. This is the original design. The problem with this design is that the weakest link is the tie base connection portion. They tend to separate from the crown or break off easily if there's excessive occlusal force. The newer, better design is called a screw-montable crown. Here, a custom titanium abutment is designed to support the subgingival area, and a crown access hole is with an access hole is cemented onto the custom abutment. As you can see here, over a period of 8 years, I have had to swap out both implant crowns on this patient. Here's another case. A few months after restoration has been placed, patient complained feeling crown is loose and gum is tender and bleeds. Notice the bone loss on the distal of the implant. What do you think caused the inflammation and bone loss around this implant? Loose abutment and crown. How do we prevent that from happening? Implant restoration and adjacent crown needs to have a broad, flat contact area instead of a pinpoint contact. We need to evaluate the proximal contact area and adjust if necessary before making final impression. How do you know you have achieved proper abutment torque during delivery appointment? Nowadays, I don't permanently seal the access hole during the initial delivery appointment. I will actually bring them back after they have been chewing on the implant crown for about a month. I will then re-torque the abutment screw to spec, then permanently seal it. This has reduced premature abutment loosening significantly. What are you guys' thoughts on placing short or narrow implants in the posterior region? Although studies such as Homley Wang and colleagues have reported that short implants demonstrate survival rates comparable to standard length implants under controlled condition, real-world experience can be much different. In daily practice, I see short or narrow implant placed in posterior region are often the first to fail. Why is that? Well, remember, the posterior molar region is subject to much higher occlusal forces, and reduced implant length and diameter limits the available surface area for osseointegration and force distribution. This increases the risk of biomechanical overload, causes crestal bone loss, and mechanical complications, particularly in patients with paired function habits or inadequate occlusal control. Long-term implant success depends not only on implant dimension, bone quality, and patient-specific risk factors, but also on sound biomechanics and appropriate prosthetic design. So I'll highlight a few factors here. First is the crown to implant ratio, just like our natural dentition, crown to root ratio. When the crown to implant ratio exceeds 1:1, bending moments increases due to the longer lever arm acting on the implant. This can result in higher stress concentration at the crestal bone level. Excess bending force contribute to crestal bone loss and increase the risk of prosthetic complications, including screw loosening, screw fracture, and component failure. Therefore, the idea of placing an implant deeper when there's insufficient bone is not necessarily the best choice. The ideal approach is to reconstruct the implant site both horizontally and vertically first, then place an appropriate size implant at the correct depth and position that adequately support the planned restoration. Another critical error I see is immediate implant placement into one of these mandibular molar root sockets rather than centering the implant in the extraction socket. Do you see a potential problem with this approach? Let's take a look. This patient received 2 mandibular molar implants in 2014. 4 years later, the patient presented with loose implant crown on number 30. The crown was removed, inspected, and retorqued in place. At the following year recall appointment, the crown was loose again. Radiograph revealed significant crestal bone loss. The abutment and crown was once again retorqued. In less than a year later, the patient returned once more. What do you see this time? Implant fracture. How did this happen? The reason this implant fractured is because the implant has been placed with a mesial horizontal offset rather than in the center of the molar site. This off-center position creates unfavorable biomechanics, increasing the bending moment and off-axis loading. Over time, repeated mechanical stress leads to screw loosening, progressive bone loss, and ultimately implant fracture. So this case highlights the importance of restoration-driven implant placement. As you can see, the replacement implant I place here is positioned at the center of the occlusal table and aligned with the long axis of occlusal load. Proper implant position helps minimize lateral forces, bending moments, and reduce the risk of mechanical complications, thus reduce the chance of implant bone loss and increase long-term success. There are many other factors, however. Due to time constraint, I will stop right here. So back to the question I asked at the beginning. When patient asks you, Doc, how long will my implant last? How do you answer it? Well, based on my clinical experience, implant complication will occur in 3 to 5 years if it is poorly placed, poorly restored, and without proper maintenance. If implant is placed ideally, but poorly restored or without proper maintenance, such as this case, I expect some sort of complication within 5 to 7 years. In this case, heavy occlusion and bruxism result loss of osseointegration in 8 years. If an appropriate size implant is placed at the ideal depth, restored according to sound biomechanical principles to ensure proper occlusal load distribution, then the patient and also patient maintains good oral hygiene with regular follow-up care, I would expect the implant restoration to last 10 years or more. Now let's discuss peri-implant disease. Very similar to periodontal disease. It is characterized by inflammation around the implant tissue, peri-implant tissue, leading to progressive loss of supporting bone. All the complications I have described so far, excessive off-axis loading, poor implant positioning, unfavorable crown to implant ratio, prosthetic misfit, all contribute to increased mechanical and biological stress. Over time, these factors promote inflammation and accelerate peri-implant bone loss, ultimately lead to implant to fail. So what I'm trying to show you is that all peri-implant complications, whether it is mechanical, prosthetic, or biological, can lead to peri-implant mucositis and peri-implantitis. If these conditions are not identified and addressed promptly, they will result in persistent inflammation, bone loss, and eventually implant failure. So early recognition and intervention are critical in preserving implant health and long-term success. This is not a new concept, by the way. In his 2016 commentary, Professor Albertson questioned whether peri-implantitis should be truly classified as a disease. He proposed that what we commonly label as peri-implantitis may, in many cases, represent progressive bone loss resulting from factors related to implant treatment itself, such as implant design, clinical error, patient-specific conditions, treatment protocols, and overall quality of care, rather than a primary pathological process. So in other words, much of the observed bone loss may be iatrogenic or multifactorial rather than solely caused by bacterial infection. While early detection and management is critical in managing peri-implant complications, prevention is the key. This means placing implants in a prosthetically driven position, augment soft and hard tissue when it is necessary, fabricating restorations that follows biomechanical guidelines, and implement proactive maintenance protocol. By addressing these factors from onset, we can minimize complication and maximize the long-term success of the implant therapy. Now, let's talk about proactive maintenance. How exactly should we and our patient properly care for an implant restoration? Peri-implant disease can progress rapidly. If not recognized and managed early, it often leads to significant bone loss and ultimately failure of the entire implant. So let's look at the implant maintenance protocol that I have developed and follow in my office. At every recall visit, my hygienists evaluate peri-implant tissues for signs of gingival inflammation and assess the implant abutment and crown for mobility. The most common implant-related complications I encounter in my practice is screw loosening. If not addressed promptly, this can lead to crestal bone loss, or if in more severe cases, implant fracture. During clinical exam, I will carefully evaluate the occlusion and make adjustments as necessary to ensure appropriate load distribution. For those of you guys who are unfamiliar with this concept, I recommend you review Carl Misch's IPO, implant protected occlusion concept, which provides valuable guidance on biomechanical management of implant restorations. If there's no signs of prosthetic movement, there's no signs of gingival inflammation, and there's no bleeding, then my hygienist will proceed with implant maintenance using an air powder abrasive such as airflow with erythritol powder, followed by subgingival flossing using an expanding floss saturated with chlorhexidine. If there's signs of gingival inflammation, BOP, and/or suppuration, then a PA is taken. I will also probe. Depends on radiographic bone level correlated with probing depth. I will then decide which therapy is appropriate. Managing peri-implant disease is very similar to managing peri-implantitis. Depends on the amount of bone loss. It can be non-surgical debridement, regenerative if possible, resective, and finally, there is the removal. The key objective is to effectively remove biofilm that is adhered to the implant surface and surrounding tissue. Although numerous methods has been recommended, most of them can cause implant surface damage or alteration that compromises healing. Among the available approaches, the only laser therapy has been shown to be effective in removing biofilm without causing damage to the implant surface. In case like this, there's bleeding on probing, there's suppuration. However, there's minimal radiographic bone loss. The diagnosis is peri-implant mucositis. Implant debridement is the treatment of choice. Traditionally, mechanical debridement is performed using titanium or plastic curettes, as well as ultrasonic instruments with implant-safe tips. In some cases, it is combined with local or systemic antibiotics as well. However, the problem with mechanical debridement is its limitation. It cannot adequately access deep subgingival areas to achieve complete removal of calculus and biofilm, and to effectively eliminate the pathogenic bacteria that is embedded within the peri-implant pocket, or disrupt the diseased pocket epithelium, which serve as a reservoir for bacteria and pro-inflammatory cytokines. So today, I prefer to use the erbium chromium YSGG laser to manage peri-implant mucositis because it allows me to overcome many of the limitations associated with conventional mechanical debridement. With a 0.5 millimeter ray dial firing tip attached, the erbium chromium YSGG laser enables me to easily navigate into the peri-implant pocket and deliver the energy circumferentially. This allows for more thorough biofilm removal without relying on direct mechanical contact with the implant surface, thus minimize the risk of implant surface alteration or damage. In case where there's horizontal bone loss and deep peri-implant pocket, bone grafting is unpredictable. My goal in these situations is to use the erbium chromium YSGG laser. Right here. My goal in these situations is to use the erbium chromium YSGG laser selectively target the inflamed, water-rich tissue and bacterial biofilm. Remove the diseased pocket epithelium while preserving healthy surrounding tissue. By reflecting a minimal flap with the YSGG laser, I can also visualize the surgical field to ensure there's a thorough cleaning, as you can see here, to ensure I can visualize the defect and make sure all the remnant calculus or cement that's attached to the implant surface to be removed. Okay, So what is the cost for this case? What is the cost for the inflammation and suppuration? Well, it is the cement. Okay. So overall, by using YSGG laser, it helps me with access, improves precision, and it helps create a cleaner environment that supports better healing. How about this case? Implant placed too close to each other. Restorations are splinted together. They're cement retained, not screw retained. It prevents a effective oral hygiene. Okay, again, severe bleed on probing and suppuration. Do we want to remove these implants? Well, that's an option, but the patient is adamant about not having these implants removed. So what can we do? Here, I'm using a ray dial firing tip to selectively remove the diseased pocket epithelium, which is infiltrated by bacteria and pro-inflammatory cytokines, while preserving the healthy surrounding tissue. With ray dial firing tip, I'm able to disinfect the entire implant pocket circumferentially. After complete the soft tissue decontamination, I will switch to a side firing tip to direct the laser energy onto the implant surface to remove biofilm, calculus, possibly excess cement. Next, I will use an end firing tip to decorticate the base of the pocket. This step is intended to stimulate bleeding and promote osteogenesis. Finally, I will return to the ray dial firing tip to achieve hemostasis and provide photobiomodulation to support improved tissue response and healing. So immediate post-op, 6-week post-op, 1 year post-op. Resolution of inflammation, bleed on probing, and suppuration. So here's another case, moderate to severe bone loss, horizontal bone loss. Again, the implants are splinted and cemented. Okay, deep probing depth, bleed on probing, and suppuration. So laser-assisted implant repair was performed here as well. Here is 1 year follow-up. As you can see, I have achieved my goal of reducing inflammation and pocketing. If PA shows angular defect, then I will perform implant repair with bone grafting. To achieve successful bone regeneration around diseased implants, several key factors must be addressed. The erbium chromium YSGG laser is the ideal tool to accomplish these objectives, as it enables effective granulation tissue removal, implant surface decontamination, and controlled decortication will minimize damage to the surrounding tissue. Let me briefly review the steps. First, complete removal of granulation tissue. It is essential to eliminate inflamed and infected tissue within the defect. Second step is thorough decontamination of the implant surface to disrupt and remove biofilm that can impair healing and reosseointegration. Once implant surface has been decontaminated thoroughly, I then perform biostimulation of the bone defect through decortication to promote bleeding and enhance the release of growth factors and stimulate new bone formation. After adequate defect preparation, bone graft material and membrane are then placed. And then the flap is repositioned to achieve a tension-free closure. So here's the case. I used water lace first to remove the granulation tissue and decontaminate the implant surface. I then used the water lace to decorticate the defect area in order to promote angiogenesis and stimulate bone regeneration. Here, bone graft placed, membrane. Finally, flap was coronally advanced and primary closure. Here you can see the dates on the X-ray, pre and 1.5 years later. Look at the defect regeneration. Here's another case, same exact protocol. YSGG laser was used to remove the granulation tissue, debride the defect, and decontaminate the implant surface. Bone graft material was then placed to facilitate regeneration. Immediate post-op, 7 month, 15 month. Here's 2.5 year follow-up. Notice the bone level gain. How about this case? Patient was referred for removal and implant placement for tooth number 13. Are you concerned about existing implant number 12, the bone loss on the distal? Whether implant can be placed at site number 13 and whether the existing implant at number 12 could remain healthy long-term depends on our ability to regenerate sufficient bone in the area. As you can see, I was able to repair the implant defect and rebuild enough bone to allow implant placement at number 13 spot. Without the YSGG laser, I don't think I can achieve this kind of result predictably. Here's another case. Patient had implant number 30, 31 placed over 20 years ago. How do we know that? Because those are Brennemark external hex implants. And 29 implants was recently placed because that is a Straumann BLT implant. Implant repair was performed using water lathes. Guided bone regeneration was performed on implant number 29 and 31. I decided to remove implant number 30 due to the amount of bone loss and the poor prosthetic placement of the implant. So here you can see pre-op, cone beam, CBCT at the 6 months post-op. Okay. Some people say, well, you can't tell if that's real bone or not on a CBCT. How about now? Is that bone or not on the facial of implant number 29? The defect left after the removal of number 30 was completely regenerated. I was able to place a new implant in a restoratively driven position as well. Let's look at another case. This is a edentulous case. This patient is 76 years old, has had these implants for over 30 years. Look at the panel. Do you see anything that concerns you? What about now? All the implants show 40 to 60% circumferential bone loss. This is why I don't think panel is a diagnostic enough to evaluate peri-implant bone loss. PA is the way to do it. Okay, so back to this case, 40 to 60% circumferential bone loss. What should we do here? Well, watch and wait is not an option, right? The peri-implant disease will only progress even faster at this stage. Could we consider removal? With such an atrophic mandible, are you concerned about jaw fracture? Not to mention the functional impact. By removing these implants, we could leave the patient without enough bone to support new implants or even a complete denture. She's going to become a dental crippled. So what can we do? In this case, I decided to perform implant repair and guided bone regeneration. Okay, here is post-granulation tissue removal, implant surface decontamination. The defect bone has been decorticated. Look at how clean the implant surface appears. Bone graft material and a collagen membrane are placed. The flap was repositioned to achieve tension-free primary closure. Initial, 1 year post-op. Almost complete bone regeneration. Look at her tissue. Instead of receding, they actually grew. So, do we need keratinized tissue around implants? Absolutely. When keratinized tissue is lacking, bacteria and food debris can accumulate under the gum, which often leads to inflammation and progressive bone loss around the implant. So this patient shows recession on natural dentition number 11, 13, and 14, and thin tissue on number 12. So what is the best approach? A connective tissue graft, a bone graft, or both? Well, in this case, I reflected flap, decontaminated both implant and root surface using the YSGG laser. Then I placed a bone graft with a membrane and a connective tissue graft around the implant and around natural teeth. Okay, here it's 1 year follow-up. Excellent tissue stability and bone preservation. And we don't see the dark grayness. Here's another case. Flap reflected. Look at the hidden recession on the natural root and on the implant. Okay, both implant and root surface were decontaminated using YSGG laser. Bone decortication, bone graft with membrane, and a piece of connective tissue. Here is 1 year follow-up, showing excellent tissue stability and bone preservation. So if implant has more than 50% bone loss or is placed in an unfavorable position, I would recommend removal most of the times. The real challenge is being able to reconstruct the defect left after removal sufficiently and predictably to place a new implant. One of the major challenges when removing implant is that the titanium particles can get embedded in the surrounding tissue. These particles act as a foreign body, can delay healing and make regeneration unpredictable. So how do we remove these titanium particles that's embedded in the soft tissue and extraction socket? Well, guess what? I use my YSGG laser. The YSGG laser emits light at a wavelength of 2780 nanometers, which is strongly absorbed by water in the tissue. This creates rapid micro explosion of water molecules in the tissue. A process is called photoacoustic ablation. The energy generated by these micro explosions physically dislodges the embedded titanium particles from soft tissue and extraction socket safely and effectively. Here, granulation tissue removed, defect decontaminated with YSGG laser, decortication performed inside and outside of the extraction socket, bone graft material placed, membrane placed, flap reflected. So in a fractured implant case like this, the implant removal tool cannot be used. The only way to remove this is what? Trephine and burr. So you're bound to leave a bunch of titanium particles everywhere. So after implant was removed, I will use my YSGG laser to remove the titanium particles that's embedded in the gum and bone. And I'll also use the YSGG to decorticate the socket wall. Here's 3 months post-removal. Here, new implant placed and restored after 3 months. Okay, so I'm going to use the last few minutes to review different types of lasers. Okay, because there are a lot of misconceptions regarding laser in dentistry. What you see here are all the lasers that's currently available in dentistry. Can all of them be used on managing implant disease like I have described so far? No. So let me briefly compare and contrast them to you. The lasers are generally grouped by the type of medium used to generate the laser beam. Different medium generate different laser wavelengths, which have vastly different tissue interactions. Dental lasers can be grouped into two types based on the tissue interaction. So on the left, what we have is what we call soft tissue only laser. And on the right is what we call all tissue laser. The soft tissue laser are ideal in managing periodontal disease because their laser energy selectively targets pigmented bacteria that causes periodontal disease and inflamed erythematous periodontal tissue. When soft tissue laser such as diode and ND-YAG is used in conjunction with SRP, what we typically see is faster healing and more noticeable reduction in bleeding on probing at follow-up appointments. Can a soft tissue laser perform soft tissue surgery such as gingivectomy and frenectomy? Yes, but remember, in order to perform surgery, you have to initiate the laser tip, which in turn turns into a what? Hot knife. So what you're doing is basically burning the tissue using heat, not the actual laser energy. So this can cause huge zone of necrotic tissue, which will cause delayed healing and increased postoperative pain. What about hard tissue? Can you use these soft tissue laser to cut teeth and bone? No, you can't, because the heat generated is so high that you are charring or carbonizing the hard tissue. Besides, these lasers are not FDA approved to work on hard tissue at all. What about all tissue lasers? All tissue lasers include erbium chromium YSGG, erbium YAG, and CO2 laser. They work by targeting water and hydroxyapatite instead, which are found in both soft tissue and hard tissue. The laser energy superheats these components, water and hydroxyapatite, producing microscopic explosion that vaporize the tissue precisely. The result is effective tissue removal while minimize the thermal damage to the surrounding structures, allowing faster healing, less postoperative discomfort. So, can all lasers remove subgingival bacterial plaque and calculus attached to the implant surface? No. If you use a soft tissue laser like the ND-YAG on titanium, you will see sparks. This happens because titanium absorbs the dark surface color of the titanium absorbs the laser energy, which can lead to melting, cracking, and cratering formation on the implant. The heat may also damage the surrounding tissue and cause necrosis and loss of osseointegration. By contrast, all tissue lasers such as water lasers, the YSGG laser, targets water and hydroxyapatite, not the titanium itself. This allows them to safely remove bacterial plaque and calculus from implant surface without causing surface damage or harming the surrounding tissue. What about CO2 lasers? This is kind of tricky because there are two different wavelengths with very different properties. The 10600 nanometer CO2 laser is a soft tissue only laser. It operates without air and water. It will cause damage to the implant surface. Whereas the 9300 nanometer CO2 laser is an all tissue laser. It also uses water and air to serve as accelerator and coolant. However, it is not ideal for implant decontamination. Why? Because you cannot attach a tip to the handpiece. So precision is very limited. You're running the risk of damaging surrounding tissue by using a tipless handpiece. So out of all the lasers, the safest, the best laser to decontaminate implant surface are erbium YAG and erbium chromium YSGG. The reason I prefer erbium chromium YSGG wavelength over erbium YAG is its ability to achieve good hemostasis without sacrificing the surgical speed. the erbium, the YSGG, erbium chromium YSGG laser penetrates deeper, up to 3 times deeper than the erbium YAG. So it cuts efficiently and cauterize the small blood vessels at the same time. On the other hand, erbium YAG energy is mostly absorbed by the water on the tissue surface. It provides very little hemostasis. That's why in a procedure like frenectomy, you see here there's much more bleeding with the erbium YAG on the bottom compared to the erbium chromium YSGG. A good hemostasis allows me to visualize the surgical field. I can see and operate more efficiently without worrying about trying to remove all the blood soaking the surgical site. Okay, so the second reason is that I favor erbium chromium YGT is really the ergonomics. BioLase Waterlase I Plus delivers the energy through a soft, flexible fiber optic connected to a handpiece that feels like a traditional air-driven handpiece. This makes access to the posterior molars, especially distal of those molars, much easier. Whereas the erbium YAG laser, on the other hand, uses a articulated arm with internal mirrors. This makes it difficult to reach those molar areas, and their handpieces are bulky and heavy, limiting the ergonomics and surgical efficiency. The third advantage is the BioLaser's proprietary side fire tip. This tip is specifically designed for peri-implant disease management. The tip bends the energy 90 degrees, allowing it to be focused directly onto the implant surface. So unlike a radar firing tip, it delivers the energy precisely without causing collateral damage while maintaining full power, full efficiency. So in summary, I want to highlight an article by Dr. Fromm published in 2017. He stated that the etiology of peri-implantitis is multifactorial, including lesions from peri-implant attachment, excessive mechanical stress, and corrosion, all in the presence of pathogenic bacteria. Like periodontitis, host resistance factors must be considered. Nonetheless, untreated progressive bone loss with peri-implant mucosal inflammation appears to be primary cause of the implant failure. Here, I like to add that prevention is the key. Before implant placement, stabilize systemic factors and treat any periodontal disease. During surgery, ensure adequate bone and keratinized tissue, and place the implant precisely with a restorative need in mind. When we fabricating the final restoration, avoid excess cement and occlusal overload. Lastly, ensure patient follows a strict supportive periodontal therapy protocol. When we treat peri-implantitis, case selection is critical. We need to evaluate and address all risk factors before we proceed to the surgical therapy to maximize predictability and long-term success. I didn't get a chance to go over all the other procedures I used to perform. I used the waterlays to perform in today. I'll save that for another session. But I truly believe that as we gain a better understanding on how and why each type of laser works, the role of lasers in periodontal and peri-implant surgeries will expand even more. In my practice, the laser has already become an indispensable tool. I use it in every single surgery I perform. There's my email, pchangdds@gmail.com. If you guys have any questions, if you guys are active on social media, you can follow me on Instagram. Just search iFix Dental Implants. Javier?
Yeah, thank you, Dr. Chang. This was really awesome. We will definitely do a part two of this, so you can show us all the other procedures that you do. Thank you so much. We do have a couple questions. So I'll go ahead and read those out to you, and then that'll conclude the webinar. The first one from Dr. Denise. Should an implant be placed immediately after extraction of a premolar?
Um, in my office, I will place a implant immediately whenever possible, whether it's central, lateral, canine, even molar, even maxillary molars. So that'll be another day we can talk about that. But if I can, I like to place implant immediately.
Excellent. This one's from Dr. Frederick Stange. Did you graft bone into the splinted implant laser case?
No, I did not, because that is a horizontal bone loss. Like I said, we have to evaluate when do I graft. I will only graft if there's a graftable defect or we call it contained or semi-contained defect. So if I do decide to graft, I would typically flap, clean, and place bone. So in that case, it's basically what I called a implant repair without a flap.
Great, thank you. Just a couple more questions here. From Dr. Pham. How was the prognosis of the dental implant if it were placed with threads above the crestal level?
Yeah, so here's the problem. So the threads, uh, if they're exposed, it attracts biofilm, attracts plaque, right? So it's hard to maintain, hard to clean. So that is the theory. So that's why there's the implantoplasty. So there's a school of thought, especially in Europe, a lot of, dentists would like to go in and plasty those implants, remove the threads to allow better oral hygiene. So I think that is a method, but I'm not too in favor of that. I can show you cases where I had patient with exposed threads and the implant lasted, is still in her mouth for 10 years. That's because patient is very diligent and maintaining and cleaning the exposed threads herself. So now if patient cannot do that, yes, it becomes a problem. It will cause more bone loss, more inflammation. So that's a different topic we can talk about later.
Okay, thanks. This one's from Dr. Shen. What BIOLASE tip do you use to disinfect the implant surface?
So I just, you pretty much can use any and all tips. So there are three main types of tips. One is called a end-fired tip, and then the other is called a radar firing tip, which emits energy 360 degrees and straight. And then the lastly is what we call a side firing tip, which bends the energy 90 degrees, allow the energy to directly focus on the implant surface. So it depends on the access, depends on whether I'm doing a closed approach or a flapped approach. I will pick different tips. If it's in a closed flap approach, the side firing tip is really the best because I can focus energy directly onto the implant surface without spreading the energy to the other side. So you get more efficient cleaning. The radar firing tip, if you don't have a side firing tip, then the next best thing is what we call a radar firing tip that will spread the energy 360 degrees. But if you do that, guess what? You're losing power, you're losing efficiency. And then there's also different tips. So brown tips is, I don't know if that's what they meant, but the brown tip is what we call zirconia tips. And then there's the clear one, it's called sapphire tips. So if you look at my surgeries, I typically use zirconia tips. These tips are more flexible, so you can actually get into the places where you need. A lot of people they like to use the sapphire, which is a clear tip. The problem with the sapphire tip is it's not flexible, it's not as forgiving. So you cannot reach into the areas that's very hard to access. The the sapphire is last longer, but doesn't mean it's the best. So my recommendations use a more flexible, disposable zirconia tips.
Great, thank you. This one might be more of an email, but this one's from Dr. Goldman. Can you give me the name of the BioLace tips and the order that you use them when you're doing an open flap surgery? Is this a long answer, or should we go with this one?
Uh, Repeat the question again.
Sure. Can you give me the name of the BioLace tips and the order you use them when doing an open flap surgery?
So I started with a RFPT tips, RFTP 514 to separate the granulation tissue from the flap. And then I will use a MZ 514 tip or 17 M-Firing tip to degranulate, remove the granulation tissue to decorticate. And then I will go back with the radar firing tip to decontaminate the implant surface or the root surface. If it's implant, I will use the side firing tip, SFT tip. And then at the end, I will use radar firing tip to do the last, what we called photobiomodulation debridement stage. So basically the three tips is the radar firing tip, the end firing tip, and the side firing tip.
Perfect. Just a couple more questions here. Prior to pre-implantitis treatment, should the crown prosthesis be removed?
Yes and no. So, there's some cases I showed here, I did not remove the crown. If I can remove them, I will always remove them. However, that comes with another whole sided issue. What type of implant is it? What kind of driver do you use? What happens if the cement is actually lodged inside of the abutment screw? So if you're going to do that, I would recommend you have two separate appointments. One appointment is just to remove the crown. Second appointment is when you do surgery. Because I had it, there are cases where I spent the whole entire time just trying to figure out where the abutment screw is at. So now, if I'm doing regeneration cases, I would typically remove the crown and bury the implant. That's when you get the most predictable bone regeneration.
Great. All right. Last two questions here. What laser setting do you use for this procedure?
There's a variety of settings. There's no one setting. You go too high, you're gonna start to cut on bone. You go too low, it's not gonna do anything. So in general, soft tissue is 1.5 watts. And hard tissue, when you're trying to decorticate, we go up to 3 watts, 2.5 to 3 watts. But there's also the hertz, there's also the water, there's also the air. So laser requires a little bit more training. That's why BioLace does a lot of these webinars. And then when you actually buy a laser, they offer multiple trainings for you to get familiar with and to be competent in operating laser. So it's a little bit different from a handpiece. This requires a little bit more tweaking. So I can't just tell you specifically, but in general, 1.5 soft tissue, 2.5 to 3 hard tissue.
Great. Thank you. Last question here. What do you tell your patients is the best for implant maintenance home care routine?
Uh, Back to the one of the, the my flow chart. So basically, I will have them clean. I'll show them how to floss around their implant with a expanding floss. I will have them soak the expanding floss with chlorhexidine. Instead of going an up and down motion, it's like a left and right polishing motion because I want them to kind of get the chlorhexidine subgingivally to decontaminate the area. This is the only time I will actually let them use chlorhexidine.
All right, great. Thank you, Dr. Chang, for your time. Everyone else, if you have any more questions that you can think of, you can come up. You can email me and I can forward them to Dr. Chang, or you can email Dr. Chang right there on pchangdds@gmail.com. Thank you, everyone, for joining us, and you have a great evening. Thank you so much.
Bye.
Bye, everyone.